Hi, my name is Stefan Knop. I'm from Würzburg University Hospital here in Germany, and we are currently at the EBMT Congress in Frankfurt. We recently presented interim results from one of our phase 3 trials in transplant-eligible multiple myeloma in first-line therapy. We compared one of the standards of care for induction, VRD, bortezomib, lenalidomide, dexamethasone, versus the triplet induction consisting of lenalidomide, adriamycin, and dexamethasone. This is a protocol which was developed a couple of years ago by our group. And the essential results question for induction therapy is basically if we can spare bortezomib for first relapse. The study has two co-primary endpoints. The first is post-induction response, comparing 3 cycles of VRD versus 3 cycles of RAD. And the second co-primary endpoints, which are not yet mature, is 3-year progression-free survival measured from randomization. The research question in terms of post-induction response was to show a non-inferiority of RAD versus VRD. And in fact, we found that 13% of patients in both arms scored CR patients after 3 cycles of induction therapy. We also did a correlative analysis in terms of minimal residual disease with 8-color flow cytometry according to the Euroflow standard. And again, 5% of patients with RAD versus 5% of patients with VRD were in MRD negative CR following 3 cycles of induction therapy. In terms of toxicity, both regimens were kind of comparable. We had slightly more cardiac events with VRD other than expected, not in the anthracycline-based group. We had a few more patients suffering from neuropathy in the Velcade-containing group, and we had slightly more patients suffering from thromboembolic events and a slightly higher rate of hematotoxicity with RAD. We also did a correlative analysis not only with flow but also with NGS cytometry. First, we found a 91% incidence of patients having a genetic marker with next-generation sequencing versus flow, and we had a high concordance rate between the two methods, but at this early time point, 10 patients who were flow cytometry negative still had NGS positive disease by MRD. And of course, we are very interested to see the co-primary endpoint, 3-year progression-free survival, as we did 2 randomizations, one for patients achieving VGPR and better. The randomization was after one autotransplant, direct switch to RAF maintenance versus a second autotransplant followed by RAF maintenance. And for those subjects not yet being in VGPR, we randomized a second auto versus an allotransplant. And we expect those data to become mature later this year, probably in the 4th quarter of 2019.